Hi everyone, I'm Sam, I'm a medical oncologist, and I've been working alongside Rob in salivary gland cancer for probably, I think now, the last 8 years or so. And anyone who's spoken to me on the phone knows that I do like to go on a little bit and chat, so apologies for that. But you've heard kind of two stories there, and I think from both stories there's things to take away of things that could be improved. And I know Ian has a feeling of a positive side of things, but I still think there's things which could have been changed, that maybe he didn't need to wait 6 months to have a biopsy. But with Jamie's story, there's certainly things that he had to kind of fight for, and if he wasn't such a strong patient advocate for himself, then things could have been diagnosed so much later. And so we've heard so much from patients in the clinic, and that's what kind of formed, and through patient groups, this research question to try and understand the diagnostic pathway. Is it just that we're hearing things from the people we're seeing in clinic, or is this a real issue that is across the country? And so we've looked at some data from our clinic here in Manchester, and we've looked at kind of the average time that patients have reported from first going to see a healthcare professional to being diagnosed with salivary gland cancer. And for about these kind of 45 patients that we've looked at, it's about 9 months, and that ranges from 1 month, so really good, to about 9 years in some cases where they've had a lump. And if your cancer was from a major salivary gland, that's a little bit quicker, it's about 6 months. If it's from a minor salivary gland, that's longer, it's about 12 months. And if it's from the trachea, so the windpipe, or going down into the lungs, then that average time, although relatively small numbers, is over 2 years. And we just don't really feel that is right. Again, though, is this what we're seeing in the clinic? How does this correspond with the UK? And so if we look at the national data, we can look at major salivary gland cancers, and we find that actually 66% of major salivary gland cancers are diagnosed at an incurable stage. So that's where we can't offer surgery or radiotherapy for these. Compared to other cancer types, if we look at all cancer types, it's almost half, so it's 46%. But the NHS's long-term aim is to get this number to 25%. So we are a long way off with major salivary gland cancer. So clearly there is something that we need to do, something that we need to change. And one of the ways that we can look at that is see how are patients accessing into the specialist clinics. And the best way to do that in the UK is through the 2-week wait pathway. That's where you get seen by your doctor, they refer you, you should be having tests and investigations within 2 weeks. And if we look at that for major salivary gland cancer, then that is only about 38%. If we look at all other head and neck cancers, that's 59%. So what's happening with the salivary gland which isn't happening with other areas in the head and neck? And so the question is, what determines these referrals? And the answer is it's guidelines. I've added a caveat since I've last spoke about this, and actually it's as long as the clinicians are following them, because we know sometimes there are good guidelines, but we need to read them, and people need to understand that they're there and they need to interpret them correctly. So what our guidelines are good at the moment, or relatively good at, is if you've got a lump. A lot in the guidance is lump, lump, lump. Okay, so we look at our data and you can see, yes, if you present with a head and neck lump, it's about 6 months. If it's any other symptom, then it's 10 months. So we need to look at those kind of other symptoms as well. So if we just go back to kind of Jamie's story, so he had a facial twitch, and the GP interpreted this as a stroke, and that's not a bad thing to do. The safest thing is to get that checked out, get an MRI, get a CT, etc. But then when that was ruled out, he was given a diagnosis of Bell's palsy. So this is where we think it's due to a virus causing damage to the facial nerve. It shuts it down for a little bit, it should come back. Now, a diagnosis of Bell's palsy is a diagnosis of exclusion, so we should rule out all other things first, and it should be only diagnosed if it's presented in a very typical way. It shouldn't have a lump associated with it, and we know that when Jamie was finally examined, he did have a lump, okay? And it shouldn't have a slow onset or be kind of starting and stopping like his facial twitch symptoms. So if actually the guidance there for Jamie's case was there, if you've got atypical presentation, he should have had a 2-week wait referral. So that's a case where education needs to come in. So the take-home message from this is that we need to update the guidance. We need to improve those guidance for symptoms which aren't lumps. And we also need to raise greater awareness of the guidance which is already there through education. So what we're doing is we are launching a survey which will go out to all patients to try and understand more about your stories, to find more of these cases, to look for specific symptoms and things which are underrepresented within the guidance to see where we can make changes. We're going to work with NICE to then try and get those changes implemented, and we want to work with the Royal Colleges and other societies to try and get better education for our GPs, our frontline staff, but also for our head and neck specialists so that we don't get cases where things are missed. So just like to say thank you, and thank you for Team Molly because their fundraising has supported my time and research. So if there's any questions or moving on, I don't mind. So it's incredibly difficult because if it was easy, it would have been done already. So when we talk about, say, for example, the trachea, those symptoms are often, it's shortness of breath, but it might not be, so much that you're really struggling. It's just noticing that you're working a little bit harder if you're going to the gym. Where we can work on there is that these are, the patients are going to be, we know, in 30s to maybe kind of 50s. We know from looking at our data, they're typically non-smokers. And so these are patients who are getting diagnosed with asthma and COPD in an age group that shouldn't be getting diagnosed with asthma, or you can test for asthma relatively quickly. Or they're getting diagnosed with COPD when they've got none of the risk factors to it. So it's trying to kind of add layers to that stratification. So, okay, if you've got, new shortness of breath, new insidious kind of cough, yes, a chest x-ray would be ordered. You wouldn't see it on a chest x-ray. But in a patient group which has not got the typical risk factors, or it's an atypical for the age, then that's where we should be making changes to the guidance. And so we have reached out to the British Thoracic Society to work with them on that. That's where it's really difficult, and especially with rare disease, because NICE uses what we call a 3% positive predictive value. So that's technical terms, but basically means if you present with a symptom such as facial weakness, and we do a test, we have to test 100 people to pick up 3 cancers. If we test 100 people and we pick up less than 3 cancers, then that is not a test which can be, or that referral cannot be endorsed by NICE under the urgent cancer referral pathway. With rare cancers, it's going to be very difficult to reach that 3%. So ways that we can do that is we try and make our symptoms more and more specific. So it's like we have facial weakness, but you have to have something else, an atypical feature. There are guidelines and there are guidelines and there are guidelines. There are so many guidelines to learn, it's very difficult. And so what NICE tries to do to help is it tries to distill it down to the things which are, very important, and that's what these urgent, cancer referral guidelines are. And they're actually quite brief. But if you look further around within the NICE website, you do find good guidelines, but it takes more time to look for it. So that's the difficulty. So guidelines can be there, trying to get people to have the time to read them is very difficult. And it's something we discussed yesterday. How do we get clinician time to provide education when everyone is already busy and overstretched and the medical syllabus is already very full? And the answer is it's very difficult, but days like this and reaching out, trying to get into the foundation training kind of program, education, trying to get into the Royal College, curriculum for new training surgeons, etc. Those are kind of the ways to do it.
It seems though that the GP really is the gatekeeper.
Yes and no. I think from our early look at the data is we do see a lot of delays from GP referral to specialist care, but we also see delays when actually you get to a specialist and then to being diagnosed. So I think both of those are relevant. But yes, so certainly getting into the GP's curriculum will be important, and working with the Royal College there.